At 2 a.m., healthcare gets very honest. There are fewer people in the building, fewer specialists nearby, and fewer backup options. And when a patient suddenly cannot breathe, the question becomes very simple. Who is there physically to recognize the problem, troubleshoot the equipment, and intervene? That is the question behind the recent discussion around Mayo Clinic's health system's reported plan to remove overnight in-person respiratory therapist coverage at several rural hospitals and use a virtual respiratory therapy support model instead. According to ABC 6 News, the reported change involves Albert Lee, Fairmont, and Lake City with overnight respiratory care from 7 p.m. to 7 a.m., supported by emergency department staff, inpatient providers, nursing staff trained for routine respiratory needs, and virtual RT consultation by video or phone. Mayo Clinic said 24/7 respiratory care would remain available with RT still in person during busier times and cited low overnight need and workforce challenges as part of the rationale. This is not an attack on Mayo Clinic. This is a bigger question. What happens when respiratory expertise becomes virtual while respiratory emergencies remain physical? This issue matters because rural hospitals live in a different operational reality. Some small facilities may have extremely low overnight respiratory volume. Some may rarely manage ventilated patients after midnight. Some are fighting staffing shortages, retention problems, and financial pressures every single day. The U.S. Bureau of Labor and Statistics projects respiratory therapists' employment to grow 12% from 2024 to 2034. With about 8,800 openings per year, which tells us demand for RTs is not disappearing. But that does not mean every rural hospital can easily staff every shift with experienced respiratory therapists. So, the devil's advocate argument deserves respect. A healthcare leader might ask, if we only had a handful of advanced respiratory cases overnight each month, is it sustainable to staff an RT in-house every night? This is a legitimate operational question, but clinicians hear a different question. Nurses hear, who will set up the BiPAP when the patient is panicking? RTs hear, who will troubleshoot the ventilator when the alarm won't stop? Emergency teams will probably hear, what happens when weather delays transport? The ambulance is 40 minutes out and the patient is deteriorating now. This is where the conversation becomes important, because low volume does not always mean low risk. Some clinical roles are valuable not because they're constantly busy, but because when the rare events happen, the consequences are high. Let's separate respiratory care into three categories. You have cognitive work, observational work, and procedural work. A virtual RT may be able to support cognitive work very well. They can help think through ventilator settings, and they can review trends. They can coach a bedside team through oxygen escalation. They can help interpret respiratory mechanics, blood gases, and device options. And that matters. Telehealth is not automatically bad. Centralized expertise can absolutely extend support to places that do not have every specialist in the building. But respiratory care is not purely cognitive. It is also observational. An experienced RT may notice that the patient's breathing pattern before the pulse ox drops, the accessory muscle use, mask leak, poor synchrony, the rising agitation, the change in breath cells. And respiratory care is also procedural. Someone has to place the patient on the BiPAP. Someone has to respond to an accidental extubation. And they also have to recognize airway obstruction. That someone should also know whether the high flow patient is stabilizing or silently failing. Mayo Clinic's own respiratory therapist career overview described RTs as professionals who assess and treat patients with breathing and cardiopulmonary disorders, monitor patient progression, assist in emergency breathing situations, and collaborate with the care team. That is not just a treatment delivery. That is clinical assessment, technical expertise, pattern recognition, and emergency readiness. Here is a key distinction. A virtual RT can guide, but someone physically present must execute. That is why many nurses are concerned, because if the RT becomes virtual, bedside nursing may become the hands-on of respiratory care. They may mean more respiratory assessment responsibility, more equipment responsibility, troubleshooting responsibilities, and nurses are already carrying a heavy workload. So when nurses raise concern about scope creep, this is not resistance to teamwork, it's a practical question. Are we adding respiratory responsibilities to nurses without adding time, training, staffing, or clear boundaries? That question deserves to be taken seriously. This controversy also forces respiratory therapists to look in the mirror. Here's an uncomfortable professional identity question. If respiratory therapists allow themselves to be seen only as the people who give breathing treatments, does that make it easier for healthcare systems to imagine replacing them? Because if the job is framed as nebulizer delivery, then the system may ask, can someone else do that? But respiratory care is much bigger than that. It is clinical assessment, it is ventilator management, it is airway expertise, respiratory diagnostics. A patient on a BiPAP who is anxious may not just need reassurance. They may be air hungry, retaining CO2, poorly synchronized, or failing non-invasive ventilation. A high flow patient with a decent saturation may still be failing because their respiratory muscles are exhausted. This is lung logic. Respiratory care often begins before the crisis is obvious. Pattern recognition before collapse. That is difficult to replace with a camera unless the bedside system is designed extremely well. The AARC responded to the report of Mayo change by stating that respiratory therapists are vital members of the care team, especially in acute care settings where rapid hands-on assessment and intervention are essential, and expressed concern about models that reduce direct RT presence at the bedside. That doesn't mean virtual RT has no role. It means the profession needs to define the role carefully. So where does this leave us? Tele-RT may be part of the future. In some settings, it may extend expertise, may help facilities that cannot recruit overnight staff. It may give nurses and providers faster access to respiratory consultation. But tele-RT should not become a vague substitute for bedside respiratory readiness without honest discussion about execution, training, workload, escalation, and accountability. The real question is not, is telehealth good or bad? The real question is, which part of respiratory care are cognitive enough to be virtual, and which parts are physical enough to require someone at the bedside? Because at 2 a.m., the ventilator alarm is not virtual. The premature delivery, the trauma activation, the weather delay, those are physical events happening in real time. And that brings us to the question, can respiratory expertise be virtual when respiratory emergencies are physical? And where does bedside respiratory presence still matter most?